Dr. Nielson, thank you as always for being so generous with your time in doing this. And I have a special introduction for your talk today. So with that said, I hand it over to Dr. David Dietz.
So thank you everyone for taking time out of your day to come to these important seminar series that are part of Dr. Clark's mechanism for funding that he got from NIDA, the HEAL initiative. And part of that was to talk to and with afflicted groups and people studying this. And so he's done an amazing job along with Jill's group to put this together. And it's been really inspiring to watch. I asked if I could give this introduction because today's speaker is Dr. Nancy Nielson, who has been a huge contributor to the medical school and to the university as a whole. Some background is Dr. Nielson is currently serving as, she's held a whole bunch of titles, but is currently serving as Senior Associate Dean for Health Policy within the Jacobs School of Medicine, and is been introduced or inducted into the Institute of Medicine or the National Academy of Medicine, is the relative or one of our celebrities who's constantly on TV for one reason or another being interviewed. And what I found has a deep passion for understanding, treating, and thinking about substance use disorder. This expands beyond just a professional, but also into different aspects of her own career and her own life, and how important and sincere she is when she talks about this particular disease state. And the final thing I'll say about Dr. Nielson is she's probably the only person in this medical school that can match me for intensity on any given day, and does that with great pride. And so I am very proud and happy to introduce Dr. Nielson and wait for her wonderful talk.
And I want to add, she's also a tremendous mentor and extremely accessible for all of us, and it's very much appreciated.
Thank you very much. I hope that didn't intimidate everybody, and I'll pay you later, David, for saying nice things.
I take cash.
So, are you ready for me to share my screen? Thank you very much. Thank you, Dr. Clark, for inviting some of us to participate in your important work. And I know David well, and I'm very impressed with the amount of research that is going on, about which I know little, but about which I care a great deal. So what I'm doing today is I decided to challenge all of us a little bit. And I am going to revisit history because it needs to be done. And we need to reinvigorate our commitment for connecting researchers with the clinicians who treat the people that they're trying to help and the community that is concerned about it. So with that, let's see. I love jigsaw puzzles. Do any of you ever do a puzzle and you get it all done except for one piece? Is that not the most frustrating thing? But the important thing is, you know the shape of the piece, right? And you also know it's in between the cushions of the couch or under the rug. I mean, you know it's there, but you know the shape. Even if you're missing a piece or two, you know what the shape is. But what if the puzzle had so many missing pieces that you couldn't discern exactly what the interconnections were, what the shape was? And that's where we are. That's where we are with addiction. And because of that, everybody has to be all hands on deck to figure out what are the interactions, what are the shapes, and that's how each of us, clinicians, families, sufferers, researchers, that's how we all contribute to figuring out how to solve the puzzle. You're going to see this line several times, that we have at UB about 160 addiction researchers, educators, clinicians on the faculty. And we have to break down the silos that have kept us from effective collaboration. And we have to interact with the people who suffer from substance use disorder and with the clinicians who treat them, because otherwise we're not going to know what the most important questions are that we need to research answers on. I want to go back to UB's Addiction Initiative. Some of you will cringe as you hear this, because you will know that this was, perhaps you may view it as opportunities described and lost. I see it a little bit differently, but certainly we have to do things differently. And the Addiction Initiative started out from a crisis in Buffalo. There was a very busy pain physician who had 10 nurse practitioners and PAs working with him. And between them, they had 10,000 chronic pain patients. And we're going to focus a lot on pain today because I think that may be our biggest opportunity locally. He was indicted by the feds for supposedly overprescribing opioids. He was a neurologist, board certified pain fellowship trained, and he was allowed to practice, but he had to surrender his DEA license. What the feds either didn't know or didn't care was that all the insurers required that for the mid-levels to see their patients and prescribe opioids for them, a physician had to be on site with their own active DEA license. And since his was not active, the clinic shut down. And those of you who were in Buffalo at the time remember this made news on all the stations, the newspaper, everything. Patients ended up flooding all our emergency departments in withdrawal. Some went to the streets to obtain opioids and had problems from those medications, which they obtained illegally. And we know at least 2 of the patients suicided. It was a true public health crisis, and it was front and center for the state health department, who frankly didn't have any suggestions about how to help us. So after about 3 weeks of this, there were 3 physicians who agreed to supervise the clinic and the mid-levels, and the physician, by the way, who was still able to practice there, but not write opioids for his patients. And so three people agreed to supervise the clinic for the summer until new management could be arranged, and I was privileged to be one of those 3. The very first day, hundreds of pain patients crowded the parking lot. Every media outlet was there. The police were there, and it was a very long day. The youngest patient that I saw that day was 47 years old, and I asked him, he looked pretty healthy, and I asked him why he'd been on opioids for years, and he told me that they started because he had had 7, count them, 7 failed back surgeries. It was not the population that I thought. I did not know the physician that I was there to supervise. And I really kind of expected a lot of, young guys with California tans and gold chains around their necks there seeking drugs. And in fact, what I saw was people in wheelchairs, people with walkers, people who had very serious chronic pain. And I learned a lot. I learned about the data monitoring program that we have to use. I had never used that in my practice of internal medicine, about how to do toxicology tests and how to interpret them, and interestingly, how to use high-dose opioids. I had never been trained to do that. But the other 2 physicians were hospice medical directors, and they sure knew how to do it, and they taught me. But one of my hospice colleagues who was there that day was Bob Milch, for those of you who've been around a long time. Bob looked at the waiting room and he said, "This is like Lourdes, but without the good outcome." Funny, but sad. And we started at 8 in the morning. At 5:30, the waiting room was still full. So Bob and I went out to the waiting room to apologize to the patients and explain to them that we had to look at everybody's chart. We had to go through the data monitoring, the drug monitoring program. But we were there until the last patient was going to be seen. We were there to help them, but we were so sorry they were waiting. And at a moment that really I will never forget, those who could stand stood, and all of them applauded. And I remember Bob Milch and I felt that was one of the highlights of our career. So out of that crisis, and by the way, a good paying physician did take over that practice, but the university said, you know, we got to do something. We have so many people across the university in all kinds of departments. Let's figure out how we're going to harness all that energy. And then thus was born the Addiction Initiative, which I was asked to chair. And that's how I met many of you, frankly. We met for months, we shared ideas, we made lots of recommendations, and we went outside of the university to talk to folks to find out what were the gaps in care and in knowledge that we could try to help fill. We were not there, and I need to make this clear, because very early on, it became clear to me that whatever we were trying to do was going to scare the service providers. They were going to think the university is trying to take over their jobs. And that was not the case. We were trying to identify gaps, and we did think big, and we got some things that we'll talk about in a minute. But as many of you know, the resources didn't match our dreams. Just real quickly, just so you can get an idea of who we talked to, I personally talked to the CEOs of every one of the service providers, the Oshai Foundation, the regional insurers. I mean, you can see it. We did a lot of information gathering, and I wasn't the only one. So what did we learn? This is what we learned. We identified 3 particular treatment gaps. One was chronic pain patients, and that's what I'm going to focus on today. But the other 2 were also interesting. Pregnant opioid substance use disorder sufferers did not have good access to treatment, and adolescents didn't either. We also learned that medication-assisted treatment was available but underused, and that is what led to the development of what I hope you know about the MATTERS treatment. If you haven't heard from Josh Lynch, you really should, because this program was born from the Addiction Initiative, was initially called the Buffalo MATTERS program, is now statewide, and actually has also been broadened into 2 other states. We heard from the service providers that they didn't have an adequate workforce, and they didn't have educational opportunities or a career ladder for them. So that was a continuing problem. And then it became very clear that there was willingness to partner and to change if we could all work together. This is an old slide. This is what we decided we shouldn't do, like build a new building and duplicate what was being done in the community, but rather the things that you see on the right-hand side. Focus on what we do best, work together, be able to respond nimbly, and have a bi-directional interaction between the clinicians in the field and the sufferers in the field and researchers, so that we learn from one another. And as you will see toward the end, aggressively pursue funding opportunities. And that was let me just say, we were disappointed in the funding opportunities, but that's nothing compared to the disappointment we're feeling now, given what you know is happening federally. So some things have changed. I looked at, you know, I hope you all were able to see Arthur Weissman's really compelling presentation. He showed you the opioid statistics here in Erie County. I looked at those to update them. I left the slides out in the interest of time, but let me just summarize that. As he pointed out, the overdoses are declining slightly here and statewide, and frankly in the US. Not really clear what that's all about. Speaking in Erie County, the demographics have changed. And if you're interested in the statistics, go to the Erie County DOH website and you can see some really nice graphs. But we are seeing more older people dying of opioid overdoses and more people of color dying. It's been a shift, and this has been since the pandemic, actually. Overdoses, non-fatal, are everywhere. Non-fatal because at least we have Narcan, and if you don't carry Narcan in your car, I would encourage you to get some and learn how to use it. because Allentown, frankly, is right where we're located, is a hot spot for non-fatal overdoses. The Matters program originated from the Addiction Initiative, from a paper from Yale that we all read in a subgroup, and we realized what the limitations were. And I hope that you will hear from Josh how that works now. But right now, which never happened before, what now happens is buprenorphine can be prescribed in the emergency room or by telemedicine to somebody who is to an opioid use disorder person who is willing to begin treatment. They can be connected with a pharmacy. They can be prescribed buprenorphine. They get, if they don't have money, they're issued a waiver. If they don't have transportation, they're issued a little chit so they can take an Uber or a cab. And the key part that Yale didn't do, that Josh got to happen in Buffalo, was he got all the addiction service agencies to agree to see these patients within 48 hours. And that has made a big difference. The other thing that has happened is we've developed an undergrad minor and a master's degree in addiction studies, which we never had before. And as those of you who were the RIA researchers, as you know, you are now faculty in various departments. Fentanyl, as you know, is found now in most cocaine overdoses, and that has become the biggest problem in our area. It's people who are using cocaine and then die when they don't even realize that the opioid is mixed in with it. And I don't need to tell anybody on this call how concerned we are about what's happening, both changes and threats of changes at the federal level. This is a slide that, given the CDC, when CDC was still able to issue comments, this is the latest stuff on how many patients in America have chronic pain, and it's 1 in 4, which is stunning. Of those, 8.5% of them had high impact chronic pain, which means they couldn't do what they needed to do during the day. This last comment here, which I listed in purple, is we really can't abandon these patients because of fear of oversight or prosecution, and yet that's what's happening in our community. I just got a call from a person that I know who was down in North Carolina visiting family, had a stroke and wants to come back, and asked me to find a primary care physician. And when I found out the person was on oxycodone, I knew I was going to have trouble finding a primary care physician willing to do that because of their concern about prosecution and oversight. And I will tell you that that's not limited to primary care physicians. Even a renowned cancer center very close where I'm sitting has trouble with this one. So it is a problem for chronic pain patients to get the treatment that they need. Well, obviously, you have to diagnose where the pain comes from first, then figure out what to do. This is just a list of a bunch of things. Some of these are not at all paid for by insurers. I sit on a statewide task force on chronic pain management. We have made recommendations that some of these things be paid for. Right now, what's paid for is trigger point injections. And that's what pain specialists do most of the time because that's where the money is. Things like yoga, mindfulness, exercise. Some of you may have heard Dr. Bansal talk last week. These are not paid for. So we're trying to get the state of New York to encourage insurers to pay for it. I don't need to stress this any more than with the audience today. You know that there is such an interaction between behavioral health, pain, and substance use. So I put these 2 slides in just to remind us that behavioral health is really critical. As my colleague, Dr. Milch of blessed memory, he died a year or so ago, said when we were at the practice, he said, a patient with chronic pain is like being from Metamorphosis. And I said, what are you talking about? He said, well, don't you remember from college reading Kafka and Metamorphosis? And then I did remember that there's a young man in that story that wakes up one day to find himself an insect, and he's on his back on his shell, and he can't turn over. The point Bob was making is it changes your life, and there are a number of things that you have to cope with. Well, most of the care that we deliver for behavioral health is delivered in a silo. These two slides are just to remind you that Nora Valco, who we had hoped would speak to us on the first and became ill and couldn't, this is not new. The intersection of opioid use disorder and chronic pain. This is an article from 2016 in the New England Journal. And these are just some excerpts, again, not new, focusing on neurobiology, focusing on depression, all of these interacting in patients with who suffer from chronic pain. And just so you know, this is not all dated. Thursday and Friday of this week, the National Academy, which I'm proud to be part of, is doing a workshop that you can sign into virtually, exploring treatment and management of chronic pain. They are focusing on disability determinations, but I think it's going to be interesting anyway. So here is the old slide we had of what was the situation and what were the emerging opportunities. And unfortunately, as you can see, the new funding opportunities did not materialize in the same way that we had hoped. And the CRIA, I mean, some of you will decry what happened. We were not responsible for that. But the point is, we can wring our hands from here to Christmas, but it's time to really get together and provide the leadership that's needed, even though perhaps the resources were not what we had expected. Here are the strengths. Just look at it. We have addiction specialists throughout the medical school. We have one of the first addiction medicine fellowships in the country, one of the first 7. We also have a pain management fellowship in the Department of Anesthesiology. We have all of these things that you can see. We have this incredible Farm Talks brain trust that many of you represent. And so we have the strengths. What are we going to do to try to help advance the frontiers of science? Just to remind you, look at the academic training resources for people who do both pain, places that offer both pain fellowships and addiction medicine fellowships. There are only 3 in New York. You can see them there. University of Rochester has pain medicine. They don't have addiction medicine fellowship. They do have an addiction psychiatry fellowship. What are the barriers? We all know, we're in silos. The people who are clinicians treating the patients don't often interact with researchers. That's why Dr. Clark's grant is so important to all of us. The researchers don't always see the patients that they're ultimately going to help, and so on and so on. These are the silos, right? Now we can either keep it that way or we can do something about it. So let's try to look at, we know the barriers, we know what we could do. Why don't we do it? Why don't we just make a determined effort to not whine about what didn't happen 6 or 7 years ago and try to figure out how we're going to really advance the science of addiction medicine? You all, some of you on this call are doing extraordinary work, bench work, which I don't fully understand, and David has to help me, help educate me on all of this. But we can make changes. The grand challenges that we determined we needed to do, look on the right side, this was at the end of the addiction initiative. We decided that revolutionizing pain management was probably the biggest opportunity. and the second one was improving maternal fetal health. And there were many others, but the point was everybody has to work together if we're going to do this. So we said there needs to be a network, not a new building, not hiring 1 million people, but a network that connects clinicians, researchers, and the patients who are the sufferers, and that we would use an explicitly interdisciplinary approach, and that we would become a true learning community. And that's my challenge, that I'm waving the flag saying, I think the will is there, the goodwill is there, and I think we can still do this. This is a logo that we put together saying if we had this response network, we've talked about the educational changes that have been made. We've talked about partnerships. You all are part of the breakthrough knowledge creation and interacting with clinicians in both preventing and treating substance use disorder, and particularly in chronic pain patients, is an opportunity that we are certainly excited about. So just imagine if our research transformed the understanding of addiction and chronic pain. If we had a community-based clinical lab that would be used as the site for testing novel approaches. And if our educational pathways that are new to UB helped train the workforce that we need. And if, when funding settles down, obviously, we then could be a magnet for both funding and treatment. Just imagine. I believe that we can lead, that we can be the catalyst. And just to remind everybody, because the public needs to constantly be reminded that addiction is a chronic relapsing disease, and every person needs to be treated with dignity and respect. If you all do not know Dr. Paul Updike, I would encourage you to meet him one of these days. He's one of the local heroes. He is the head of addiction services for the Catholic health system and was an enormous help to us back during the public health crisis that I described, and continues to be a help and a leader in educating the community and how to bring compassionate care. So I want to go back to the jigsaw puzzle. There are lots and lots of missing pieces, but I think we do have the opportunity to do something about it if we break the walls down of the silos, interact with each other, learn from each other, and rise to meet that challenge. And that is it.
I'm happy to help field questions. Stuart, did you want to say anything?
I think Stu had to go teach.
Yeah, he had to leave at 12:30, he said.
Oh, okay.
And I see several others have as well. So first of all, I want to thank you all for listening, and for revisiting what for some of you might be painful memories. But what are we going to do about it? Are we going to wring our hands forever? Or are we going to really try to still accomplish what we know we could accomplish?
Dr. Oldani has his hand up with a question.
Hey, thank you, Dr. Nielson. I appreciate
Hi,
the
Mike.
talk
How
so
are you?
much. I'm good. 2 comments and then a quick question. One comment, really appreciated your interdisciplinary and, of course, interprofessional approach to the problem. And
If you
also,
all don't know, Mike is our guru of interprofessional education, and we're thrilled to have lured him here from his cushy job where he was before.
oh, thank you. Also, the behavioral psychiatric integration to the problem. And I guess my question is more, it's from an interprofessional point of view. It's pretty clear the data is showing drugs like buprenorphine and Suboxone can kind of be this bridge to pain management, but there still seems to be this gap where we're not able to get the message out or the training out. And so, for example, even in my own family, we've had missed opportunities where people with chronic pain, opioid use disorder, for some reason, they that just opportunity doesn't present where they can get on these different medications. And I'm wondering what your experience has been, out there in the real world, with these other drugs we can use for both opioid use disorder and chronic pain management.
Well, you raise an interesting issue. Let me just tell you how bad it was, because the pain physician who was indicted, one of the charges was that he was using buprenorphine for pain patients who might have a substance use disorder, and they didn't think that should be done. That, of course, is now well recognized as a standard of care. But that's you know prosecution lags behind scientific understanding. Let me just say that as kindly as I can. So you're right, but there's still much we need to do. There was a recent study that I just was in one of the journals within the last week or two, where they took chronic pain patients who were on high dose opioids and tried to taper them downward. And in one case, they used buprenorphine to try to taper. In the other, they simply tapered the opioids. There was no difference. There was no difference in how quickly they came down. There was no advantage to buprenorphine over regular tapering, which was a surprise. I mean, we thought that it would be faster, and so I think there are a lot of questions about that study. I'd like to see it replicated, but there's much we need to learn, and the gaps between what we've learned at the bench and at the getting that to the bedside, as everybody knows, takes years. And it takes more than that for federal prosecutors to understand the science. If we don't have any more questions, I'll give you back the rest of your hour.
Well, I'm sorry. I am still in charge a little bit, so I want to close things out. If anybody doesn't have any other questions, Dr. Nielson, I think a number of us have heard your explanation and the history of what you went through as a team for our community, and it's daunting, but it's also inspiring. And I think one of the things that in second with what Dr. Oldani said is that, our office is here to support investigators, especially if they want to approach things from an interdisciplinary perspective as related to research. Put teams together, team science. That's one of the things that we aim to do. And just the fact that you highlighted all of that is, again, very much appreciated. We were lucky to get you back here in Buffalo with all of your experiences, and are so fortunate to have your leadership at UB. So
can I just say one thing, because I know some of the people on the call are working on cocaine, and
okay.
you heard a wonderfully honest presentation from Arthur Weissman some weeks ago, and so I want to share my own story here. I have a family member who was tragically addicted to crack cocaine for 15 years. And so, that's how I, as an internist and an infectious disease person, became interested in this. And so for those of you working on the neurobiology of cocaine addiction, I want to thank you, because there was no treatment. It was awful. He's doing fine right now. But as Dr. Dietz and I talked about this morning, you always worry about the future. But I want to thank you for the research that you're doing that may help us have a better understanding of how this happens, what the changes are in the brain, how we can prevent and treat it. And so I just wanted to add that personal thanks.
Well, we thank you again for sharing all of your insights, for taking the time to prep for this, and for all the ways that you guide. Very, very much appreciated.